With regard to simulation, and I present Dr. Olsen.
Thank you. Thank you very much, Dr. Jernigan. We're good to go over here? All right, good. So disclosures first. So we're not talking about simulation today, but I am a consultant for Gamard Scientific. And if you serve on the editorial board, that's considered a conflict. And I'm on the board of directors for Advanced Life Support Obstetrics, but we're not doing maternal health today, so I think we'll be good. And I am a textbook editor, so you get a free chapter today. Don't even have to pay for it. Dr. Holmes is going to write a chapter too, so maybe you'll get a free lecture from her as well. So is Dr. Assad. So with all these conflicts, you'd think I'd be rich, but it turns out I'm still driving a Toyota. So I got interested in this topic way back in my residency. At that time, there was no one lower than a resident, so the residents did all the sexual assault evaluations in the hospital. And it'd be 2 o'clock in the morning, somebody's upstairs, 7 centimeters. We have to run down and do a sexual assault evaluation, get it done within 15 minutes so we can run back upstairs and deliver this baby and this multiparous patient moving rapidly. It was terrible care. As residents, we hated it. We liked the patients. We wanted to do a good job, and it was just terrible care. And so we all felt like we were doing the see-me side of medicine because we weren't giving these patients what they needed. And fortunately now things are better in much of the world, and I'm sure it's better where I was a resident as well. And we have a little more organization. But I think you're going to learn that the healthcare system is really not doing a good job taking care of these patients and making sure they get what they need. And that's part of what we need to know. Because these patients show up in our office with problems we're going to discuss, and they also already have a jaded view of the healthcare system because of what they experienced. And so they might be mad at us when we didn't even do anything. So it's common. And many of the term survivors is preferred over victims because human beings don't like to see themselves as victims. So therefore, if you refer them to victims, some people actually feel reviolated because they don't want to see themselves as a victim. So I'm going to use the term survivors instead. And the spectrum is large. So if a person says to an employee, you want to keep your job, well, then we're going to have sex, that's coercion, that's sexual assault. And then forcible rape is another end of the spectrum. And then there's subsets. Acquaintance rape, date rape, statutory rape, child sexual abuse, and incest are all in the spectrum of what patients experience. For today, we're going to confine this to adult sexual assault, and students will talk about pediatric sexual assault when I give my lecture to you. And it's like I mentioned, it's a very significant problem. 190,000 patients a year in the U.S., 18% of women in a large study, so you're talking 1 out of 5. And they're very underreported. Most patients just decide not to report it. And then they come to our office and we don't know it either, and then they've got some of these other problems that we're going to get into. So other injuries, so not just the genitals are injured. So severe injury, these are patients will come in with life-threatening injuries. And the risk of a severe injury is increased if the perpetrator is a former intimate partner or current, if the rape occurs in a home, if the survivor is threatened, the risk of an injury is higher, if a weapon is used, and if the perpetrator is using drugs or alcohol. And then we've got long-term effects. So the first 3 are more psychological. And then the second 3, this is what we see as gynecologists in our office. So the patients can have chronic pelvic pain, dysfunctional uterine bleeding, dysmenorrhea, sexual dysfunction. So it may not be they actually have any more dysfunctional uterine bleeding than the patient who hasn't been sexually assaulted, but it bothers them more. And so they're more likely to come and see us. So one of the things that has happened to me is that patients are not always comfortable being honest about this question. So I can remember a patient that I was just suspicious she had sexual assault. I asked her, she said no. A couple years later, I asked her, she said no. Finally, after a period of time, she trusted me enough. And she said she'd been sexually assaulted, and we got her into some treatment. So I decided, I'm going to look through the chart. How long has it been? 10 years. So it takes that long sometimes for people to begin their recovery. And then alcohol abuse has definite links So half of women seeking abuse treatment for alcohol abuse were found to have a history of sexual assault. So if your patient's an alcoholic, ask them if they've been sexually assaulted. If your patient's been sexually assaulted, ask her about alcohol abuse. It's that tight a link. So we're going to now talk about the patient sitting in front of you. Imagine that you are a medical student who's decided to go into ER, or you're in a hospital system somewhere where the gynecologists are doing the rape evaluations, unlike our system where our residents actually don't get to see too many acutely sexually assaulted victims. And so they're going to, so for the residents, this is so you know what your patients go through. And for the students, some of you may end up in ERs. So remember, the physician is a healer, but the physician is a forensic evaluator. This has very significant legal significance. So you screw this up, somebody may walk and go rape somebody else. That said, the rate of prosecution is about 1%. So you want to have empathy, you want to have sensitivity, you want to have a non-patronizing attitude. And interestingly, patients are more likely to have injuries at other areas of their bodies than the genitals. So we're taking care of the whole patient here. We're not focusing on her genitals, we're focusing on the entire person. So in that time when I was a resident, I probably did 100 sexual assault evaluations. And I clearly remember one where the patient comes in with orbital fractures and disconjugate gaze, and she's got potentially life-threatening intracranial injuries, and they're calling the gynecology resident to examine her genitals. So keep in mind, does this patient have something that she might die from? That's a good rule anytime you walk into a patient's room. Does this patient have something bad that if I miss it, some severe harm could happen? But it's especially true in evaluating sexual assault victims. In many areas of the country, including Johnson City, Tennessee, we have a nursing program called the Sexual Assault Nurse Examiners. I've got a couple more slides talking about them a little bit later. And these are trained nurses who come in just to see this patient and spend time with this patient. So from the patient's view, it's a marked improvement over what I described from 25 years ago, because this patient comes in and has one person that their job is to take care of that patient. And so while there's a code going on in one room and a motor vehicle accident in another, she's got somebody devoted to her that didn't have to run back and forth to take care of those other patients. So these individuals are trained to deal with that patient. They're trained to collect evidence, and they're trained to get the patient into some follow-up. So the same program, Sexual Assault Nurse Examiners. So if you're an intern and your patient calls you and says, I've just been assaulted, one of the things, this is the list of things you'll tell the patient before she goes to the ER to get evaluated. So avoid putting stuff in her mouth because she may have been orally violated. Avoid bathing or showering. That's going to get rid of evidence. Avoid changing her clothes. Again, evidence. And avoid cleaning her fingernails because there may be DNA underneath fingernails. And then when you're actually seeing the patient, first thing, make sure she doesn't have a life-threatening injury. Make sure she can consent, because she has to consent to a forensic evaluation. So if she's had a date rape drug and her friend brings her in, she can't consent. So then you get her consent, and that's usually in writing for the forensic exam. And there are patients that come and say, no, don't want to do that legal stuff. I just want to make sure I haven't been injured. And assuming the patient's an adult, we would certainly honor that request. We might try to talk her into getting the forensic exam just in case she changes her mind, but that's the patient's right to say, nope, not doing it. And then the medical emergencies. So when you're taking your history, if she has a history of asthma, she might get an asthma attack. If she has a history of a seizure disorder, she might have a seizure while you're doing this. So just get your medical history quickly and be prepared for the fact that she might have a negative event related to her medical history in association. So here's some of the history, some of the important questions. So the students actually get a copy of the chapter, and so when we have our session, I like the Socratic method. That means I get to be Socrates. So I'll be asking you what questions will you ask the survivor when you see her. So some of these are pretty basic, what, when, where, but contraception, something we forget to ask sometimes. The approach in the history is one of professionalism, and there's no better time to be a professional than with this patient, because she's just been in a life-threatening situation, afraid of perhaps even being killed, and to have somebody come in and say, I've got to ask some embarrassing questions now. Well, that doesn't help her a bit. She needs a professional that comes in and treats her like she's got any other disease. It has an ICD-9 code, yes. We have ICD-9 codes for sexual assault, so it's a disease. And act like a professional and say, ma'am, we are orally violated, anally violated, or rectally violated. Just use medical terms, treat her as a professional. She can draw some healing from your professionalism. More questions. Did the rapist use a condom? They might do that to avoid the DNA evidence. Last tetanus shot, something we forget to ask. If your patient's 30, maybe her last tetanus shot was in high school. She might need it because she might have abrasions from the other injuries. Last consensual intercourse, you're going to do a wet mount in your exam where you're going to check for motile sperm. And so if her last consensual intercourse was last week and she's got motile sperm from the assault she says was 4 hours ago, you put that in your chart. It's just more information corroborating her testimony. And critically, will she be safe? If she was sexually assaulted at home and the rapist is her neighbor, you might need to find some other way to keep her safe than send her home. Now in the physical exam, and again, making sure she does not have severe life-threatening injuries, some other injury besides the sexual assault. Face and breasts are common targets, and in a pregnant woman, the abdomen's a common target. Document the injuries. Some folks will take photographs, some people do drawings. I think it's going to, if this was a case where you went to court, how are you going to feel the most comfortable? Showing a photograph to the jury, showing a drawing to the jury, and you just decide what you're going to be the most comfortable with. There's not a legal standard for this in 2014. Remember, she might have alcohol or drug intoxication. You're going to collect the specimens, and good light is essential. Patients are violated by foreign bodies, so if there's a laceration at the top of her vagina, maybe it went into the peritoneal cavity, maybe she's got a bowel injury, maybe she's got a risk of peritonitis and death, so you just have to keep that in mind. Specimens for gonorrhea and chlamydia, vaginal secretions that we mentioned, and then expect the anus for injury as well. Okay, so for the medical management, assure the patient's safety and privacy, treat the physical injuries, discuss results with the patient, discuss results of her pregnancy test. The pregnancy test you're going to get is very critical because if she's pregnant, it wasn't the rapist, and you can tell her it wasn't the rapist. In terms of if she waits 3 weeks and has a positive pregnancy test, she doesn't know if it was, the rapist or her current partner, and so for making decisions for pregnancy termination, getting a pregnancy test is extremely critical. So, right answer on large multiple choice exams is you will check for sexually transmitted diseases. If a person I've had this conversation with a person who works in the same program, and she says, we would never check that because if she comes back with chlamydia, then the defense attorney for the perpetrator is going to say, well, look at her, she's promiscuous. Obviously, she just changed her mind afterwards. I mean, if she's got chlamydia, she must be promiscuous, and therefore my client over here has got to be innocent. And so that's why they don't. And so you're going to have to decide yourself when you're in there what the right answer is. And part of it may depend on how readily is this patient going to follow up. If you're afraid you'll never see her again, you might lean towards getting it. If you think she's going to follow up in a month, you might lean against it. The reality is you're going to prophylax her against gonorrhea and chlamydia anyways, so at some level, you don't need to ask her if she ever had chlamydia because you're going to prophylax it. You can make a case you don't need to ask her. You don't need to test for it because you're going to prophylax it. Emergency contraception. So certainly must keep that in mind if the patient's not on a contraceptive agent. Tetanus booster. Okay, so those of you that have done your reading, what's new in the last couple of years is trichomonas being prophylaxed with metronidazole. That was not on the list of things that we did just a couple years ago. HIV prophylaxis for anal assault, that's also new. And then the hepatitis B prophylaxis could be considered. So to talk about the changing gears slightly, so we've talked about being a healer. Now we're going to talk about being a member of the medical legal system. So you provide an accurate medical record, and remember that this is a record that might well be read in front of a jury. 1% is still 1%. You're going to document the injuries. You're going to collect the samples. We're going to go through that a little bit. And then you're going to look at the vaginal fluids and identify the presence or absence of semen. And the kit also has things in it to check for prostatic secretions. So, chain of evidence. Chain of evidence means that, so this is what the sexual assault kits look like. So the chain of evidence is it goes from law enforcement's hand to healthcare provider's hand. Healthcare provider does the exam. Healthcare provider hands it back to law enforcement. If the law enforcement person was called away for an emergency, and you say, "Oh, ward clerk, would you give this to the officer when she gets back?" You violated the chain of evidence. It's all going to be thrown out, and you have no chance for prosecution. So if that happens, you lock it up and wait till law enforcement and your hand, law enforcement's hand. Chain of evidence is maintained.
Are those provided by law enforcement?
That is correct. They are not stocked in the ER because theoretically somebody could break in and put evidence in them. So no, when the ER has a sexual assault victim, they call law enforcement. Law enforcement comes in with the kit in law enforcement's hand. That's correct. And we'll talk a little bit about testimony in a moment. So that's just a picture of the kit, and inside has all these envelopes. Some of the envelopes have, so just like much in life and medicine, the kit might not be exactly the same when you actually see it, because the cheapest kit might be a different company next month. It might be this company again 6 months later, and a third company next year. So they have different numbers of envelopes. So some of them have very, very thorough envelopes, including pulled pubic hairs, and some of them have very scanned envelopes. Some of them have instruments get under the fingernails. Some of them don't. So they do have directions. So a real patient in the region was transported to Johnson City Medical Center because the doctor, quote, didn't know how to do a rape exam. So here's the thing, they have directions. If you're a doctor and you can read, you can do a rape exam. And that's just, just think how that patient felt. Doctor refused to take care of her and ships her 2 hours away after she's just been assaulted. So laboratory. And here again, the blood tests. So if you take a population of sexual assault victims, they have a higher HIV rate than the general population. That would be a reason to get an HIV on these patients. If the patient turns out to be HIV positive, the defense attorney is going to use that and say, of course she's promiscuous, that's how she got it, she's lying, let my client off the hook. So there again, the answer on your test is get it, the answer in reality might not be get it. You're going to have to decide that if you're taking care of these patients. And date rape drugs are not detected in drug panels for drug abuse. So if you just get a drug screen, it's going to be checking for cocaine and marijuana, and it's not going to be checking for the substances that are used for date rape. So you have to get a separate panel. You can order a separate panel for drugs of date rape, and that's the panel you need to send off. It's just interesting to contemplate some of these things we read about women passing out because they were too drunk, and the articles tend to say how they're fairly negative toward the survivor of the assailant. And the articles don't even tend to mention the fact that somebody may have slipped a date rape drug in on top of the alcohol. And I'm sure that's what's happened many times. I've had patients that have been raped after date rape drugs, so they exist in Johnson City, Tennessee. All right, so pregnancy prevention. So the rape-related pregnancy rate is 5%. I mean, that is high. That's 1 out of 20. So when you think about those 190,000 rape victims, that's a lot of pregnancies. So how is this? So look around yourself when you're taking care of obstetric patients. And things I've really seen are patients screaming and screaming and screaming, and somebody wisely says, well, she should have thought about that before she got pregnant. Well, maybe she didn't have a chance to think about it. Or nurses doing a vaginal check, patients screaming, running up the table, the nurse says, how did she ever even get pregnant? Well, maybe this is how she got pregnant. So just keep in mind when you've got these patients that are outliers, maybe there's a reason that they're an outlier. So high rates, so we definitely need to treat these patients or offer them treatments. Plan B, levonorgestrel. Is that abortion pill? Is that what that is? No, it's not. It's birth control. It's high-dose birth control pill. So as a scientist, I mean, levonorgestrel is in many birth control pills. As a scientist, I'm going to say that if it's unethical to give Plan B, it's unethical to give all birth control pills. It's the same drug. How can you say levonorgestrel is ethical in an oral contraceptive, but it's not ethical in a post-coital oral contraceptive? Ella is actually slightly more efficacious, so if you have a choice, you're going to pick Ella. Copper IUD is the classic treatment, so that's the classic answer. There are some books that are now just saying IUD, so I'm not sure what the answer is going to be on your triage, whether it's going to be IUD or copper IUD, because I'm now seeing both, but for up until just a couple of years ago, it was only a copper IUD. It was a post-coital contraceptive. Mifepristone, that is the abortion pill. That used to be called RU486. And it works. It works as in fact, it's much more effective than levonorgestrel or Ella. It's $300 a pill, and it only goes to physicians' offices, and you have to plan for it in advance, so it's not practical in the United States, even though it's more efficacious than Plan B is what is used more commonly in our region. Okay, these studies were done, they took a group of patients, they tested them at the time of the assaults. So many studies have been done with these ranges of disease transmission. And then they test them after the assaults. Apparently they didn't prophylactically treat them. And let's find out if you get gonorrhea or not. I don't think I could get that one by the IRB, but that's... So the different studies have shown rates of 0 to 26% for gonorrhea, 4 to 17 for chlamydia, and 0 to 19 for trichomonas. So I mean, certainly you get rates in some studies of 20%, 1 out of 5. And yet when ER studies were done, rates as low as under 7% of prophylactic treatment have been reported. So this is another theme that I'm going to hope that the patient shows up and says, yeah, I was treated in the ER. Don't just check, oh good, she's treated, I don't have to worry about that, because ERs miss a lot. So you actually need to pull the record and make sure she got her antibiotic treatment, because there's a significant number that don't. So don't just, you know, and unfortunately that's part of medicine, is you can't always trust your colleagues. Anybody can have a bad day. So don't assume your colleague did everything right, because maybe your colleague didn't. And we've covered this before, but then you know, this is great multiple choice fodder here. So things to commit to memory right before you take the test, and then after you take the test, you can pull out your reference of choice and look it up there. All right, HIV. So it's not standard of care in 2014 to treat everybody for HIV. And the CDC does not yet say if they're anally assaulted, you should treat them. But there are authors out there that are saying that. So I think it'd be my recommendation that you go ahead and do that. If the survivor's been violated by a receptive anal sex. And you see the rates there, so the rate is significantly higher, 20 to 30 times higher for receptive anal sex. Other reasons why you might, if a patient says, I want it, I would recommend you give it to her. But it's not standard of care to give it to every rape victim, rape survivor at present, because the rate of continuing the medication is low because of the side effects. So if we get some medications that have less side effects, that might change the recommendation as well. But you see the list of other risk factors, so multiple assailants, mucosal lesions. It's known that the assailant has a high-risk behavior these lacerations and abrasions will all be reasons for you to consider HIV prophylaxis. And there's some of the regimens there. And the side effects, gastrointestinal upset, liver enzymes, neutropenia, renal toxicity. So these are reasons why we don't want the cure to be worse than disease. Okay, so hepatitis B, also acquisition has been reported. So if you're practicing in a region with high prevalence, then you probably ought to consider rapid course vaccination or hepatitis B immunoglobulin. And so the usual course of vaccination takes several months. There is a rapid course, which I assume is less efficacious compared to the long-term course, but more efficacious if you just had a exposure recently. So your short-term medical follow-up. So patient needs counseling. She needs it significantly. And then the follow-up pregnancy test in 3 weeks. There will be a time that you need to get the STD analysis. So repeat is what the answer would be on your test. If you decided you weren't getting it the first time, then you'd get it the first time here. And then the HIV, hepatitis B, possibly hepatitis C at 6 weeks, 3 months, 6 months is the current recommendation. It used to go out to a year. Now the recommendation is stopped at 6 months. So let's talk a little bit about court. So one of those patients I saw when I was a resident, I got called into court for, it was 100, so it consists of 1%. This patient was violated with a tree branch. I sent the bark as evidence. What do you think the defense was? Who wants to guess? What's the usual defense for sexual assault?
Consensual.
It was consensual. That was the defense. Defense won that case. So just keeping in mind that anything you put down there is going to be used in the legal setting if there's a prosecution. Your job, if you're on the stand in a case like this, your job's not to convict anybody. Your job is to tell the truth. Now that said, the defense attorney wants to make the doctor look incompetent. Because how could you let this incompetent idiot put my wonderful client here in jail? So they do attempt to make the doctor appear incompetent. So another case that I testified in was happened to be a 6-year-old. She was taken out in the woods and assaulted, kidnapped from her bedroom. And I saw the lacerations on her vagina. I irrigated her vagina. I saw 2 sperm cells. And I should have used a woods lamp because it would have lit up probably was on her thigh. But I spent my half hour. I saw the 2 sperm cells. And now I'm testifying 8 months later. And I had made a mistake in my documentation because I said that there was no penetration, because that meant I didn't need to go worry about a laceration or upper vagina and peritoneal injury and all that. So medically, no penetration to me meant I don't have to go do an x-ray of her abdomen looking for the diaphragm. Legally, no penetration meant she wasn't raped, at least according to the defense attorney. So he spent a half an hour trying to make me define penetration until I finally wised up and said, all I know is an adult male penis touched this 6-year-old's vagina, leaving abrasions and sperm, which I found. Then we decided to change gears. And it probably was the 2 sperm cells that put him in jail. So you have responsibility of the truth, but you don't have to convict anybody. You do have to tell the truth, though. I would say it's your responsibility of the justice system to not allow yourself to be manipulated. And it's comment, hey, I don't understand this, Dr. Olsen. Can we just meet and have a little conversation? That's from the defense attorney. Well, what's going to happen is that, now, Dr. Olsen, we met on July the 11th, and didn't you say, and that's what's going to happen. So you don't have these meetings. Unless you work, sure, let's have a meeting. Let's set up a deposition with the prosecutor. The prosecutor will be there, you'll be there. We'll just do this formally. That's how you do it. Because then the prosecutor's there to redirect, et cetera, et cetera. So, I mean, the plaintiff has rights. The alleged perpetrator has rights. And certainly we have to go in the legal system, and certainly there are alleged perpetrators that are misidentified or whatever. And so we have to cooperate, but we don't have to cooperate on their terms, we cooperate on our terms. So we discussed the same program a little bit before. So these are the things that they've described. So the survey was, tell us about your last trip to court. What happened? And so it's interesting because, we doctors, there's a lady in there bleeding all over the floor. We run in there, we solve the problem, we do the C-section, we save the patient's life, the baby's life. And then we go to court where nobody's going to die and we're just trembling and can't hardly even sit up straight because that's not our environment. So just keep in mind, if you're in this situation where you're in court, but yes, bad things can happen, but nobody's going to die in the next 10 minutes and you've handled situations worse than those. So the testimony is unnerving because we're not used to it. There are a few doctors that love court because they like to match wits with the attorneys and prove that they're smarter. So they're rare, but they do exist. There are doctors that really enjoy court. So difficulties with the defense attorney regarding the victim, that would of course be most likely trying to portray the victim as promiscuous. The defense attorney has questions about the exam or the evidence, so just like I talked about, penetration. The defense attorney says the examiner's not qualified. So yes, how many of these have you ever done, Dr. XYZ? And the prosecutor is poorly prepared. That's kind of sad. That's true. So comparing sexual assault to medical legal liability. So most obstetricians are sued once every 10 years. I am above average. And I've had 2 depositions. Have not yet had the thrill of going to court. We spent probably 10 hours before each deposition. We're talking about money now. Now, medical legal system talk about people's lives. I have walked into court cold. Nobody even had a conversation with me. So we're going to spend 10 hours to save money, but we don't have time to even have a conversation over the phone, which might result in somebody going to jail for years or going out to rape others. It's just interesting, the dichotomy. So just to review your legal responsibilities: accurate records, document injuries, collect the samples, analyze vaginal fluids, complete the reports, ensure chain of evidence, and be prepared to offer testimony. So the real reason that physician didn't go didn't know how to do a rape exam was probably she was afraid to testify. And I hope I've conveyed that it's anxiety provoking. It's not something to be afraid of. It's our obligation to our community. We went into medicine to serve our community. This is no way to serve it. All right, so shifting gears now back to the patient. Long-term consequences. So these are some of the psychological ones, mental health ones. So post-traumatic stress disorder. So for post-traumatic stress disorder, you have to meet these criteria. And the criteria include a recognized life-threatening event. And it doesn't have to be a life-threatening event to the person. They could witness an event on a loved one. That would also be criteria for post-traumatic stress disorder. And you have to have some type of recurrent memory of the event. And that can include flashbacks or nightmares and things like that. And then you've got to have some long-term consequences. So certainly sexual assault meets the criteria for an acute event. So patients will suffer from that. They are more likely to have major depression. They're more likely to have suicide attempts. And the rape trauma syndrome. So there's an acute event, and they have disorganized lifestyle. They have self-blame. So when you're seeing these patients in the office, this is not the time in their life to get a new job, get a new husband, make any big changes. This is just not the time for that. They need to get through the first phase before they start making lifetime changes. And then there's the second phase, which is long-term, which can include some of the components that we mentioned of post-traumatic stress disorder with phobic reactions, nightmares, and sexual dysfunction. So patients don't realize it takes so long to recover from sexual assault. So the patient might think that 2 months she's going to be back to normal, and that's not the reality. So I can clearly remember a patient that was so proud because after 4 years, 1 day went by where she didn't think about it. And I mentioned the patient, it took her 10 years to trust me enough talk about the history. So it's, yeah. I have met patients that are in their 60s that it appears they had sexual dysfunction throughout their marriage, and then, yes, they were, when you get a history from them, there was sexual assault in their background. So it has long-term, lifelong consequences for some patients. So I've got this slide down here twice, just because I think it is so important, because I'd like all of you to think about this in your differential diagnosis when you've got the patient that no matter what you do, you can't make her better. Maybe you're treating the wrong problem. So just keep that in mind, that for all of these conditions, differential diagnosis includes history of sexual assault. So screening. So ACOG encourages screening of all patients. And then, again, I mentioned to you that patients aren't always comfortable on their initial intake evaluation or even later talking about this. So you're allowed to ask again. So for sexual dysfunction, pelvic pain, dysmenorrhea, dysfunction, uterine bleeding, you might want to ask again. In a survey of patients, did your doctor ask you if you were sexually assaulted? Less than half said yes. And women overall in the same survey feel comfortable with screening. I would say that means women overall. The individual patient sitting in front of you might not feel comfortable with it. So there are times where you realize that you're now disrupting your physician-patient relationship if you push. So maybe you ought to wait a few visits and try again. Because there is a cohort that's not comfortable. So women overall feel comfortable? Yes, that's what the literature says. My own experience is there's a cohort that doesn't feel comfortable with it. Okay, we talked about substance abuse, and again, if the patient has substance abuse, screen her for sexual assault. If she has sexual assault, screen her for substance abuse. So there are some patients that have increased risk, and so these are patients that are more vulnerable, and you need to keep it in mind and perhaps warn their family members, caregivers, the patients themselves, depending on the situation. So these patients at high risk, so disabilities that limit activities of daily living. What that means is if you can't run away, you're more likely to be assaulted. Cognitive deficiencies, so your patients with developmental delay are at higher risk than the general population for sexual assault. So that is, when you see a patient with developmental delay for her annual care, that's a question you need to ask. Is she safe? And these are patients that can't even tell you sometimes that they're being assaulted, so they may have a sudden behavior change. So they may present, their diagnosis of sexual assault may present because of their behavior changes. Lesbian, bisexual, transgendered individuals are more likely to be assaulted. Younger women are more likely to be assaulted than older women. Single and separated divorced women are more likely to be assaulted than married women. And this 20 to 25% of college women may be assaulted in their college years. That's a controversial number. I would say if it's half that, it's still way too high. That's the number that I think the Obama administration is using in their efforts to try to promote increased understanding this is a major problem on college campuses. But there are those that think that number is too high. But again, if it's double that, so what? And it's still half of that would be much too much. So prevention, what can we as doctors do? It hasn't been studied well. So there are only a few studies on sexual assault prevention. Most of them are in colleges, and only 2 of the 5 studies showed some success. And there are no studies on sexual assault prevention programs based in the office. So I don't have any evidence to stand up here and say that we can make a difference in our patients' lives by telling them about sexual assault. It logically makes sense that it would, but there's not an evidence-based study that I can pull out to show you that it works. But I do it anyways. So what we can do, we can identify the vulnerable patients. So that list we saw a few slides ago. If you have identified a vulnerable patient, at least talk to the patient about it if she's capable of the discussion, or her caregiver if she's not. Make sure the patients are aware of it. And this is, the patients frequently do not know how common a problem it is. So when you have the assault victim, to explain to them it's a common problem, that normalizes it for her and helps with her healing process. But when you have the adolescents you're educating about sexuality, you need to talk about assault as well so they understand it's a common problem. And that's, again, when you're sexual assault prevention, reminding especially the adolescents that sexual assault is linked with drug and alcohol abuse. That's just one other reason to avoid drug and alcohol abuse. Educate patients about date rape drugs and advise patients to be aware of personal safety at all times. And then just a few, so this, we've covered most of this, but I guess the thing we haven't covered is because they're trained to do this, they provide better evidence than people that haven't been trained to do it, which does make some sense. So there are directions, but experience, like much in life, makes you get better. So there's a good study. I've got the references are all at the end, so when you pull up the CME PowerPoint here, you can see the 48 references. But poor care can impede recovery. So if you're giving the patient poor care, she's been violated, she goes to a place, she gets bad care, and now her chance to begin her healing did not occur, and so it's going to take her even longer. So things that happen is providers aren't experienced with it. And I think we have to admit that there are some providers that don't want any experience with it, and so they avoid it, and so then they don't give good care, and they can be decades into their career and they've been avoiding it the whole time and they never do give good care. Because if it's 18% of the population, we see these patients every day. That's the bottom line. If you're a gynecologist, you see these patients every day. Providers may adhere to rape myths. They may accept stereotypes, and they may be disrespectful or inconsiderate. So real things that have happened is, well, what did you expect? You're wearing those boots. I mean, providers have actually said that to patients. So if you see these types of things, that's an opportunity for you to educate your colleagues that, excuse me, but that was inappropriate. I mean, there's just no other way to phrase it. So some of the rape myths. Rape is provoked by the victim. That was a real line a person told me she was told during her evaluation for sexual assault, so I didn't make that up. Rape is provoked by the victim. Promiscuous women are the ones that are raped. The patient can resist the rape. Women respect men if they're overpowered, and rapists aren't really responsible. They've just got all that testosterone. They can't control themselves. So those are rape myths that patients have believed that their providers have adhered to. And some of the rape survivors, their constructive criticism to us as providers, they wish their providers had been better trained. They wanted to talk about it, but because the provider didn't ask about it, they just didn't feel comfortable bringing it up. So again, that's where the screening comes in. Or they felt that they weren't being believed, or even they were blamed for getting assaulted. And again, they point out that the failure of healthcare professionals to do their job well trivialized their experience and was actually harmful to their healing. So how do we support the survivors? So one of the things about the SANE program is it's not based on let's get the evidence, all right, thanks, see you later. It's based on we're going to help you. That's getting the evidence is just part of it. So we're going to take care of you tonight, we're going to give you your medicines tonight, and then we're going to set you up for counseling tomorrow. And so it is a treatment-based program that forensics is one component of it. And those are more helpful for survivors than just a program of get the evidence and send you on your way. Just keep in mind that ER is the first and only opportunity for acute treatment for many programs. So I think there are 300 and some SANE programs in the United States. Well, there's a whole lot more than 300 hospitals in the United States. So that means that most places do not have a SANE program, and they're just getting the docs doing their job in the ER. And so that sometimes means that treatment opportunities are missed. So many components of post-assault care may be missed in the ER, and then patients frequently billed for the ER evaluation, and that's felt to be a barrier. So because you do have patients that don't have health insurance, so they can't afford to go get another bill. So here's some of the missed opportunities. So this is a survey of ERs. What do you do? So look at that. 50% provide on-site emergency contraception. I mean, half of patients walk out there with a 5% rate of pregnancy without getting offered emergency contraception. And then over half have no counseling follow-up arranged. So 82% do provide STD prophylaxis, which means that 18% do not always provide it. So those patients are walking out the door at risk for gonorrhea and chlamydia. So concluding remarks, it's prevalent. The effects are acute and chronic, and in some cases I would add lifelong. Sexual assault victims frequently report suboptimal experiences with healthcare systems, so it's up to us when we identify that. I mean, you're allowed to apologize. I'm sorry that happened to you. You're allowed to send a note to the hospital administrator. And patients actually, just generally speaking, if they feel you're your advocate, that at least helps them feel like somebody cares. They feel better, at least for a little bit. Somebody cared enough to send it up the chain. And it's appropriate for all of us to work with communities to provide improved care. So, what questions do you have? It's a sobering lecture, so I realize we're not bounding with enthusiasm here.
Who sees the sexual assault patients in the Johnson City Medical Center emergency?
So we have a SANE program, and as an aside, the SANE programs throughout the country are being afflicted with funding decreases because the healthcare system is struggling right now, so many of them are closing, so the rate of number of SANE programs is actually dropping, not increasing, which is unfortunate. But as of right now, we have a very good SANE program from what I can tell.
Do they come in and do the evaluation?
That's why yes.
Do the sexual assault kit?
That's what I understand, and hasn't changed over the last few years.
And if you would like to help the SANE program this year, usually in about the beginning of March every year, they have a 5K race called Take Back the Night, and it's put on by the SANE program, and is funding for our program is enhanced by that. So if you want to do something for the SANE program,
Good thought.
as well as
Get some exercise.
It's been run in 70-degree temperatures. It's been run during snow, so I know it's in early spring. So, but it is a very good program, and funding from that goes to utilizing. There are pieces of equipment that apparently do help, and most of these people who are part of this not only are survivors themselves, but also are a man at desk hotline.
Right, I mean, they're at home and they get a call at 2 o'clock in the morning, they get out of bed and they come in and they take care of these patients. So it's very valuable and they deserve our respect, without a doubt. And yeah, I think there's a small stipend, but I'm sure it's not worth frequently getting out of your bed at 2 o'clock. I'm guessing it's too small to, it's a thank you, it's not really a job. Yes?
2 questions. One, what's our hepatitis B prevalence in East Tennessee?
From what I can tell from just looking at prenatal labs, it seems low. I don't know if anybody wants to disagree. Dr. Wells does not want to disagree,
There's more
no.
people being vaccinated now as part of the routine vaccinations. I don't remember what year that started, and most of the ones in medical school that are older or beyond have been required. So there's probably just a small gap of people, so probably looking at your older population more so than your 20-somethings, unless they didn't have a complete vaccination series.
I don't see it very much, but I didn't think I didn't know if it was higher.
I don't think it's higher than.
And then when you say that the ER only gives 50% prophylaxis for STDs, are you saying that they write scripts or they provide it on site, like actually?
The questionnaire said on-site prevention, so that's what the questionnaire said.
That was, I mean, if you provide 4 scripts for a 10-care patient, that's all that they're going to get for that month. So I just didn't know if they gave it in the hospital or not.
So I don't know what this hospital does.
So if I listened correctly, you had 100 times went down to the emergency room to do a evaluation of a sexual assault, and 2 times you were subpoenaed?
That was actually a different hospital, so once for that hospital. Once.
We had the same situation in the days before SANE programs and before emergency department physicians took over. The senior gynecology resident was always the first line of questioning for a sexual assault, and I had a similar situation as Dr. Olsen, but in my situation, it was the additional information that actually played a role in the conviction of the individual. Apparently, he had grabbed the survivor by the throat, and I had examined and noted that there was some reddened areas around the throat, and put that in my history and physical. Came out at trial that over the next 3 days, as observed by her roommate, these became bruises and became damaged blood vessels, and I was asked to explain how that could be red at the time and then develop, and I explained the damage to blood vessels and then the seepage of blood, and I do believe that that led to more of a conviction. So it is important to look at other parts of the body so that you can understand.
So did you have more than one testimony when you were a resident?
No, I just had of all the sexual assaults.
Did you think you did 100 as well?
I can't remember if I did 100. I don't think we did because there was. I don't think so because the other hospital got more of those.
Okay.
Dr. Olsen went to the other hospital. They got the knife and gun club. Although on my emergency room time, I got subpoenaed twice.
Well, I'd like to mention one little thing. I don't know if it was really talked about here. In my experience, same sort of situation, you get called in, you have this rape kit and whatever the workup is. And one of our attendings, private attendings, was called. And he got to the emergency room and of course was told by the emergency room people that he was not on the list to do the evaluation. So while I did the evaluation on the patient, he spent the next 35 minutes sitting in the lobby holding the hand of the patient's mother, who was a patient of his. Kept reassuring her that he had trained me and I was good and I knew what I was doing. And as far as a bad situation goes, he really made it as good as it possibly could have been.
Very talented physician, sounds like.
You know, just dealing with the family is something we don't really talk about much either. I remember in Charlotte, we would get these young women in, and the mothers would bring them in and say, I need for her to be worked up for rape. And you'd start the examination, and the mother would say, you know, I saw the young man jump out of her window, so I know she's been raped, and that's the 5th time this week, and that sort of thing. And so somebody else has to deal with the rest of the family while you're doing the evaluation.
Yes, I guess the last patient I saw was an adolescent. She came to the office, and her story was that she went to the adult ER, and they said, we don't take care of kids, you gotta go to the pediatric ER. She went to the pediatric ER, and said, we don't do rape in the adult ER. So she showed up in my office the next day, and we were not gonna send away a 3rd time. So the officer came to the clinic with the rape kit, and we did it. So you may still, at some level, if you get a chance to do these evaluations, I think the residents should do them if they get a chance. On the other hand, the system I described in the past where we did them all was obviously the wrong system. I think it would be good if you had an opportunity to go through the process so you understand it. All right, thank you very much.
Very good.